biggest unmet need in AL amyloidosis that we still diagnose the patients at a very late stage. So I think it's very important that each hematologist, oncologist, or even each internist understands that it's very important to think about amyloidosis when patients have an MGUS smoldering myeloma, Waldenstroms, and they present suddenly with symptoms like unexplained dyspnea or diastolic dysfunction, and patients do not have hypertension. Also, if patients present with a left ventricular hypertrophy but have a low blood pressure, or patients come in and say, I had to take high blood pressure medications, but right now I don't do that. Actually, my blood pressure is pretty low. If patients have at the same time in MGUS or multiple myeloma, think about AL amyloidosis, unexplained proteinuria, hepatomegaly, also autonomic dysfunction, such as an orthostatic hypotension or GI dysmotility, can be signs of AL amyloidosis. I think early detection is an unmet need. And the second unmet need is make sure that you have the right diagnosis. If patients have a diagnosis of amyloidosis per tissue biopsy and they have at the same time an MGUS, do not prematurely conclude that those patients have AL amyloidosis. Patients can have an MGUS. Actually, it's pretty often in older patients. Up to 5% of our older patients have an MGUS. And it's very possible that those patients at the same time have TTR or senile amyloidosis. So you do not want to treat senile TTR amyloidosis, wild-type amyloidosis, or hereditary TTR amyloidosis with chemotherapy. So I think this is also important that those patients have the right diagnosis. And I would say the third unmet need is really what can we do to bring patients into a deep and long-term remission? I mentioned already daratumumab, but don't forget transplant. I think even if you use Dara and Cybo-D as an induction regimen, transplant as consolidation to achieve a deep remission and a long-term remission is something that will help patients to have a better outcome. Don't forget that patients who receive the transplant and go into a CR have an almost median overall survival of 10 years. So transplant is still an excellent, I would say, treatment option, but I'm well aware that only up to 20% of the patients are transplant eligible.